everyone. I'm so glad to see so many people here. We're always worried about the weather, how cold, and people coming out. And as you know, if you want to, as with all of our presentations, this is being recorded and the videotape will be sent out to everybody next week. So if you want to, watch it with your spouse or share it with your team or whatever, you'll be able to have it. And all the rest of our videotapes are on our website, spednet.org. Dr. Kalikow has been here before, and we asked him to come back because people loved him so much, and we haven't addressed psychiatric meds in a while. He is a child psychiatrist in private practice for over 30 years. He speaks widely on the use of psychiatric meds in children and adolescents, and he is the author of Your Child in the Balance, Solving the Psychiatric Medication Dilemma, and Kids on Meds, Up-to-Date Information about the Most Commonly Prescribed Psychiatric Medications, which is a guide to psychiatric meds for non-medically trained mental health professionals. We're presenting this in sponsorship with the Wilton Library, Wilton Public Schools, Wilton Youth Council, and Newtown Sped PTA. And Dr. Kalikow will tell you about the books that he'll have later. In the back, we have a list of all of our presentations. Most of them, we add some as the year goes on, so please feel free to take a copy. And there, I think, are 2 additional copies of Attitude Magazine and Attitude Magazine, the 2 magazines about, especially about ADD, that are terrific, are in the back. Thank you.
Welcome, and thank you for having me back. I want to just get organized here. So just in terms of time, so it's now about 10:20. I want to leave time for questions. So I'm going to talk until, I forgot what we decided, but I'll make. Okay. So get comfortable. And give me just 1 second. Okay. So, a few years ago, I was in a cab. This is pre-COVID. I was going to a conference. I was in a cab with a nurse, and we were both ended up in the same cab going to some conference, and we're going from the airport to the conference, and we get to talking, and she found out that I was a child psychiatrist. And she said to me, "Do you believe in medicine?" And I thought to myself, that's such an interesting and awkward question. I mean, it's like if she said to me, "Do you believe in God?" I'd say, okay, like that's a fair question. I mean, it's a little maybe personal for a cab ride, but I can deal with that. But do you believe in medicine? And it struck me that medicine, she was seeing medicine as a belief, okay? And medicine is not a belief, okay? Medicine is a tool. And we're going to talk about using the tool of medicine and how one decides to use the tool of medicine. But I want to get it out of that kind of religious thinking into kind of more scientific thinking. Now, and the talk will be, we're going to focus on ADHD, but I think that there'll be a lot of principles that we'll talk about, certainly in the beginning, that will be germane to really any medicine in child psychiatry. And the truth is, any medicine, period, and any form of treatment, as you'll see. Okay. So our goal now in this discussion is going to be not, medicine as belief, but the responsible use of medicine and how to measure that. So whenever you make any decision, you as a decision has a problem, okay? And what I was pulling out of my case, as Eve said, I have a few of Your Child in the Balance if people want to buy them. I had a few. I don't have the kids on meds. So if anybody can answer this question, I will just give you a book, okay? So he who has a decision has a problem. Who is Harvey Hubbard Westervelt III? Not even a guess. Okay, no book. So Harvey Hubbard Westervelt III was my college roommate. He was of he is of Dutch ancestry, and he used to have this quote that his father used to tell him. And this is basically where parents are. Okay, this is where we all are as patients. So we have to come up with a way to decide if medicine is the right decision. Now, in all of child psychiatry, this is my first commandment. You have to start with a good evaluation. We could spend a long time talking just about this slide. It's worth its own discussion, which we don't have time for. And I was talking to one of you sitting outside before the talk started, and we were talking a little bit about availability of child psychiatrists and how medicine becomes more corporate and time gets shrunk, and those are big problems, and I'm not minimizing them. I'm simply saying that from a kind of philosophical point of view, you have to start with a good evaluation. You don't start with just a quick checklist from Time magazine. Okay, that might get you going in a direction to get a good evaluation, but you have to have a good comprehensive evaluations. Now, who does an evaluation? I mean, I don't say this glibly, competent people. And what I mean by that is, does it have to be a child psychiatrist? No. I mean, you get a certain type of evaluation from a child psychiatrist. You can get a similar but sometimes slightly different evaluation by a child psychologist or somebody else who is a mental health professional who deals with children. But it's really more about the person's competence than it is exactly what specialty they are. And child psychiatrists don't simply do medication evaluations. Okay, if a new patient comes in to see me, I do a complete evaluation. I'm looking for everything kind of in my realm. It's not just, does this person get medicine for ADHD? I want to know, for example, do they have major stressors that that could have been post-traumatic stress disorder? Is the child depressed? Is the child anxious? How is the child doing in school? How does the child get along with his or her siblings, with his parents, friends, et cetera, et cetera, et cetera. Okay. So after you do that evaluation, you come up with, in my head, kind of a list of signs and symptoms. Okay. The interesting difference here is it's a little. It's important to me, but I think for most people, it's kind of a little factoid for a cocktail party. So what's the difference between a sign and a symptom? A symptom is a subjective experience that the patient has. So you go to the doctor, I have a bellyache. That's a symptom. The doctor, kind of percusses around and says, well, you have a sound of X right here. That's a sign. So we look at signs and symptoms, and we decide, does the person have a diagnosis? Now, diagnoses are not necessarily bad. It's just a kind of a shorthand that we use to say we have seen this group of signs and symptoms before. We've, as a professional in the field, we've seen these before, these signs and symptoms, and we know, hopefully, maybe we know what's causing it, and we can set up a prognosis and a treatment plan. And that's basically what a diagnosis is, but it's not necessarily bad. There are two types of diagnoses, though, and we have to make that distinction before we go forward with ADHD. Categorical diagnoses and spectrum diagnoses. So this person has a diagnosis. It's a good diagnosis, okay? This diagnosis made me a grandfather, 13 years ago. But it's categorical. What I mean by that is that this person, my daughter, she has the diagnosis. She couldn't have this diagnosis a little. Okay, she either has the diagnosis or she doesn't. She has it. Okay, so that's a categorical diagnosis. This, when you guys drive down toward the city, you've seen this tree. And I took a picture of it because every time I passed it, it reminded me of the tallest kid in the class. Like, I'm thinking back of my sixth grade class picture. And there was always, so-and-so who was always in the back row, towering above everybody else. And then, the middle height kids kind of in the middle, and then the shorter kids were always down at the bottom. Height is not a diagnosis, but it's a characteristic, and it's on a spectrum. So does the person in the tall person who's towering over everybody, is that a diagnosis? Do they have two tallness or something like that? It sounds a little glib when I talk about height, perhaps. If we move it to, say, weight, okay, where does obesity become obesity? Where does it become morbid obesity? When does it become a disorder? And I'm not an expert in weight, but you see where I'm going with this. It's on a spectrum, and we're going to be talking about that. That's going to be kind of important to what we have to say. So if we look at ADHD, is ADHD a categorical diagnosis or a spectrum diagnosis? Most people, just without giving it too much thought, I believe, think of it as a categorical diagnosis. My son has ADHD. Fair enough. And the truth is that that's kind of where the field has been since about 1980. So for over 40 years, that's, you have a list of signs and symptoms, you fit the signs and symptoms, you have the diagnosis, categorically. But is that true? So this study, which was done about 10, 12 years ago, they looked at pruning, which I'll explain to you in a minute. They looked at pruning in 4 groups of kids. Now, first, what's pruning? So when you're born, you have the neurons, the nerve cells of your brain. You have something like 100 billion nerve cells, and they each connect with a few thousand others. And so you end up with, if you do the math, let's call it 3 trillion connections. Okay, now a connection, just so that we're clear, is not, they don't touch, it's not that kind of connection. It's a connection like that. So there's a little space between them, but the synapse, but let's just call it the connect, it's a connection. In the first few years of life, you get more of these connections. And within a few years of life, like by, I think, let's say age 6, your brain starts pruning. It starts taking away the connections that are kind of, let's call it overgrowth in a sense. Okay, so as a way to make your brain more efficient, your brain, when you're a child, starts pruning. I think of it almost like a gardener who's got, you got the shrubs with all the branches, and they kind of prune it to make it look neat and, in a sense, more efficient garden. So what the researchers here did is they took 4 groups of kids who had ADHD by the book. Then they took kids who had a lot of ADHD signs and symptoms, but really not enough to get the diagnosis. Then they took kids with a few signs and symptoms of ADHD, and then they took kids with no signs and symptoms of ADHD. And they measured their pruning over the course of time. And what they found was that the group over here, that's the group with no signs and symptoms, pruned the fastest, followed by this group, and the group with ADHD by the book were the slowest pruners. So there are two interesting conclusions from that. One is that kids, ADHD improves, okay? So that, to some extent, and we'll talk a little bit more detail about that later. But you can see how even the kids over here, the kids with ADHD, they prune. The group is just kind of pruning a little slower. It's almost like you have a gardener, with arthritis. The gardener's going to get to the place pruned. It's just going to take a little longer. So they'll get there. The other interesting thing that you see here, though, is that you can feel the biological spectrum. So, the slowest, fastest, fastest, slower, slowest. And you can feel that biological spectrum. So is ADHD a categorical diagnosis? We still use it that way, but I think what you're going to see over the course of the years is that's changing as more research comes in about the brain. Okay. So what is this thing that we're calling ADHD? So ADHD, the simple way of looking at ADHD is it's kind of in the title, attention deficit, hyperactivity. Let's add the word impulsivity in there. So disorder. Now, but you want to see those signs and symptoms in more than one sphere of life. So that if a parent comes in to me and says that, Johnny is all over the place at home, hyperactive and impulsive, and the teacher says, I don't know, Johnny sits like an angel. He's right up front. He's paying attention. Well, I've got to figure that out. I can't just say Johnny has ADHD. You want to see the signs and symptoms in two or more spheres before you make that diagnosis. Number two, you want to see the signs and symptoms kind of from early in life. Now that's an evolving concept also. That's changing. So, you can hold me to this for now, but I think it's going to change. And the more data comes in, we find, there are more studies showing ADHD starting for some people later in life. So let's not go there. The most important thing here, in a way, is the bottom, okay, the bottom line, which is that you're looking for impairment. And this is a Starbucks conversation. Like, we can meet in Starbucks after this and have a long discussion about this. But it becomes a discussion of when do characteristics become a disorder? Why not simply call if Joey is hyper, a little fidgety and squirmy and impulsive and unfocused, why do we have to say he has ADHD? Why don't we simply say those are his character? That's kind of who he is. Well, so that's a long, complicated discussion, but the short of it, really, I think, is do those signs and symptoms cause clinically important dysfunction? Now, you can say to me, well, by whose criteria, who decides that? What's dysfunction? If we all have different thresholds for dysfunction, both as people, and I might have a different threshold for dysfunction for my patient than you have for your child who is my patient. In other words, you might say, well, he's dysfunctional, and I might say, well, I don't know, he's not dysfunctional. He's not maybe functioning as well as he optimally could. Is that dysfunction? It's a very sticky wicket. And so, but it's important. Okay. If we look at ADHD over the course of years, is this a new issue, ADHD? No. Kids who have what we call kind of textbook ADHD, just for the purposes of discussion, have been around forever. Okay, well, they were around, if you just look at literature, If you go into the library here and find some, old books, written by whether it's American authors, of the 19th century, or I'm guessing you can go back to Greece, to ancient Greece, you're going to find people who fit those criteria for ADHD. In 1902, Dr. Brill described this and wrote about these children. And then we had, but nothing much was made of it. And now we have to consider what the world and the world of science was in those years. In 1918, we have the flu epidemic. And after the flu epidemic, there were a lot of kids who were noted to have become hyper and impulsive. But that was because of the flu. That was because they had encephalitis from the flu. And so it was a clear cause of them. Again, not a whole lot happens with it. By the 1950s, psychiatrists were seeing what they called minimal brain dysfunction, which is a funny label. The reason they came up with that label is I think it was minimal brain dysfunction. It was minimal because it wasn't maximal. In other words, it wasn't after you had encephalitis. That would be kind of a maximal kind of cause. Whereas here, they couldn't really find a cause, and so it was called minimal. And brain dysfunction, because that's where we were in the 1950s. It's not liver dysfunction, it's from the brain, so it was minimal brain dysfunction. By 1968, it became hyperkinetic reaction of childhood. So so DSM, let me just explain DSM, you probably know. So DSM, the Diagnostic and Statistical Manual, is the American Psychiatric Association's criteria for all disorders. And it first came out, I think, in 1953. I've never seen that. And then in 1968, DSM-2 came out. It was an update. But I will tell you, and I don't have it with me, but I have that. I have two copies, actually. They're about that thin, like maybe 100 pages, like that. It's not much more. It's not more than that. And child psychiatry in there is almost 2 pages, 2 sides. Okay, that's the whole of child psychiatry. And that reflects kind of where child psychiatry was in those years. And what's interesting about hyperkinetic reaction is why the word reaction. Like, that's a very funny word to have in a diagnosis by today's standards. And I think the reason for that was that back in the early 60s, being impacted by the 1940s and 50s, psychoanalytic thinking was so strong, it was such a mainstay of psychiatry that, basically, and this is, again, this is a little glib, but it gets the point, is, back then, whatever problem you had, basically it was your mother's fault, okay? And so you went to therapy. And again, I don't mean that, it's funny, but it's also true, and not to minimize the importance of those years and the doctors who, what they came up with. In many ways, it changed culture. However, it came out in a diagnosis, hyperkinetic reaction. By 1980, which is why I said 1980 earlier, DSM-3 comes out. It's that fat. And it has now lists of signs and symptoms, and you need so many to have a certain diagnosis. And then DSM-4 comes out, and a few years ago, 10, I think, years ago, DSM-5 comes out, and they're basically the same as DSM-3. There's no major difference. Although the only difference I will tell you, because it will clarify things for some of you, when people say ADD, which I still do sometimes, that's really wrong. Okay, ADD left. It was in DSM-3 in 1980, and I think by the time that got revised a few years later, or certainly by DSM-4, which I think was 1994, I think, or 6, ADD left. And it became, and the reason it left is because it was noted through research that the kids who were inattentive were not that different in terms of course than the kids with inattention and hyperactivity, okay, and impulsivity. And so the mixes, so what happened in the 1990s is it became ADHD, and you could label either predominantly inattentive. So those are, again, with all due respect, the kids who we call space cadets. So inattentive type, there you could have hyperactive impulsive type, and those are the kids who are all over the place, or both combined. So when people say ADD now, it's technically it's not right, but again, we all do it. Now, so I just gave you kind of the simple version of ADHD, but ADHD is much more complicated than that. And research is showing that, and clinically seeing patients shows that. Kids with ADHD not only have inattention and hyperactivity and impulsivity, they're forgetful and they're disorganized, and their impulsivity is not just like knocking over the blocks, but they can have emotional impulsivity. So they kind of blow their temper in an instant, and then 30 seconds later, it's like, pass the ketchup. It's like never happened. There's procrastinating. I mean, that's a big one. So there's lots and lots of angles and signs and symptoms that kids with ADHD have. And then we have comorbidities. So what comorbidity means are other diagnoses that occur with the ADHD. So if a child has ADHD and they become depressed, in other words, having a depression, not just they become sad, but they have a depression. Now you have ADHD comorbid with depression. So those two things are comorbid. And kids with ADHD tend to have lots of comorbidities. So that complicates the world. They have comorbidities, probably off the top of my head, I'd say the most common is oppositional defiant disorder. And if I remember correctly, this figure is up around 60% of kids with ADHD have comorbid ODD. A lot of kids, maybe it's 30%, I forget, have anxiety disorders. Some have depression, learning disorders, and language disorders, very common. So that also kind of complicates the life of somebody with ADHD. How do you know? So this goes back to that first slide about starting with a good evaluation. What is a good evaluation for kids with ADHD? For me, it's the same as it is with almost anybody. Sitting down with parents and getting a careful history. Seeing the child, although you don't want to be fooled by how the child acts when they're in the office, because sometimes the child comes into the office and sits down, perfect gentleman, and then you talk to the parents and the teacher and they say, like, he's all over the place. Either you got him on a good day or, he kind of held it together for a little while. So you can't be fooled, but seeing the child, hearing from the school staff, sometimes rating scales are important. They kind of help you make it a little bit more objective. Psychoeducational and neuropsych testing can be very important. It doesn't necessarily, the neuropsychologist might make a diagnosis of ADHD. However, and that's perfectly valid, you don't need the neuropsychologist's evaluation to make a diagnosis of ADHD. Okay, ADHD is a clinical diagnosis. You make it based on history and observation and all these things. You don't necessarily have the neuropsych, you don't necessarily need the neuropsych evaluation, although for some kids, it's very useful. And because there may be other things going on also that you want to know about. And then medical evaluation. You don't want to miss something that's medical. Is that frequent? No, but it happens. You have kids, I've had kids who've had seizure disorders, in particular what are called absence seizures, where the seizure lasts maybe 3 seconds and the person is basically motionless during the time. So they're talking. I'm sorry, what was I saying? That was what it looks, that's a rough imitation. Okay, if you have those through the day, then you're going to be very unfocused. I mean, you're not really unfocused, you're having seizures. Okay, and you need to see the neurologist to kind of get that diagnosed. And again, I'm not saying that it happens frequently, but it happens. You want to know that the child is hearing. Otherwise, and seeing, things like that. Okay, there is no blood test, there's no biological test for ADHD. Not yet. And I look forward to the day that it exists. So I'm not sure it's going to be in my career. Now, so what about the diagnosis of ADHD, and is it increasing or decreasing, and is it really as common as everybody says? If you go back to, let's say, the 60s and 70s, when this is before ADHD inattentive type was really recognized, the prevalence rate was about 3 to 5% in the United States. Now, interestingly, in other parts of the world at that time, the threshold was much higher. So in a study, what was called the Isle of Wight study off England, they did the prevalence of various disorders in, I think it was 10 and 11-year-old boys. And if I remember correctly, they interviewed 1,000 plus boys and their families, I think, and had maybe 2 cases of ADHD. That's like 1 in 1,000, 1 in 500. I mean, very different than 3 to 5%. As the world has kind of come together over the past decades in using the same criteria, though you see that ADHD actually exists around the world and at roughly the same prevalence, not exactly, like different parts of the world are some are higher or lower, but in the same general ballpark. And now, when you add in inattentive ADHD, also when you add in a closer look at girls who were kind of overlooked 50 years ago, you find that the rate, I mean, I have here about 8%. More recently, and this might be post-COVID, I'm not exactly sure, is more like 10%, which raises an interesting point that we're going to talk about in a minute. The point here, though, is that ADHD is basically, it's not an American disorder. It's around the world. Again, depending on criteria and thresholds and things like that. Now, what causes ADHD? Think of ADHD as a biological disorder. Okay, we left remember the hyperkinetic reaction of childhood from 1968, influenced by the 1950s and 60s. We're past that. No, mom, you did not cause your child's ADHD. This is a biological disorder. Is it a well understood biological disorder? No. More information is coming, with every year and every decade, and we understand the biology somewhat better now than we used to. But think of it as biological, and probably largely genetic, but not genetic. The geneticists should forgive me for saying this, not kind of simple genetics like, mom and dad have red hair, and so Joey has red hair. Like, like we learned in 10th grade biology. Not that simple. There are lots of genes here, and they have kind of various strengths, if you will. But think of it as a largely genetically based biological disorder. And that's important when you think about how you approach your child. And the analogy being, you don't yell at your asthmatic child for wheezing. And you shouldn't yell at your ADHD child, for being impulsive. Now, we can argue, are those really analogous? And okay, so we can have an interesting discussion there. So maybe they're not exactly analogous, but there's a core truth that you should take home with you, that we're talking about a biological disorder. So does the environment cause ADHD? No. Can the environment exacerbate ADHD? Absolutely. So if we just take the example I just gave you, and the child is being impulsive, and the parents are yelling and screaming, and you fool, you're not like you're as good as your sister. Just all the things that we all kind of now lose ourselves and say to our children that we shouldn't. Can that exacerbate things? Absolutely. And so that's worth remembering. Now, so a few minutes ago, I said we're going to talk about that in a minute, and what that is yes, ADHD is a biological disorder, but when you pick it up, you don't have to read this, by the way. I'll explain it to you in a second. But it's not, no disorder exists in a vacuum. Every disorder exists in some kind of an environment. And the environment impacts both who is seen as having a disorder and how that disorder manifests. So, and there are a bunch of studies done, actually, this is just one of them, that looked at if you look at kindergarten children, where you put the deadline for who makes it into kindergarten or not affects the number of children who get diagnosed with ADHD. And in short, the kids who are the youngest in the class tend to be diagnosed more often. Now, that does not mean that this is the school's fault, and it doesn't mean that it's, that they're picking up, they're making ADHD, that doesn't exist in anybody. Like, it exists in some kids, like even the oldest kids, some of them have ADHD. But if you look comparatively, you find that the younger kids tend to get diagnosed more often. And I think that perhaps is a reflection of how teachers' expectations change in those early, or don't change, but the kids are different because their ages are different. So that if you take somebody who's 5 and 2 months and versus 5 and 10 months, that's a big difference in terms of development. And it's just worth remembering that. So it does kind of point out to some extent how environmental expectations impact whether a particular child gets diagnosed. Now, what happens with ADHD? Is it this thing that sometimes people will say, oh, he's just Huck Finn. That's all ADHD is. Well, that's simply ridiculous. And if you look at the research on follow-up studies of kids with ADHD, and just to be clear, remember the experiment with the 4 groups? Okay, the fastest, slower, slower, slowest. Okay, we are talking now about this group, the kids who have ADHD by the book. If you look over decades of research, you find that kids with that ADHD have, more ER visits, more medical issues, more cigarette smoking, more sexually transmitted diseases, more being left back, more, you can read it. It's just, and more. So ADHD is can be very significant disorder. Now, to be clearer, probably more of the kids who have more of the negative, kind of dangerous outcomes are kids with ADHD, probably with more often with comorbid, either oppositional defiant disorder or even conduct disorder, which is kind of more rule breaking, if you will. So it's not kind of that all kids with ADHD end up like this, but they're more liable to. Now, here's Kalikow's rule of thirds, which is roughly true. Okay, it's true enough to use it. About a third of kids simply outgrow their ADHD. And I think that's the kids who are slow to, or slow but making reasonable speed in terms of pruning. About a third of kids will outgrow their ADHD, usually sometime in adolescence, let's say. About a third of kids continue to have some of the symptoms of ADHD, but they are overshadowed by the child's assets. So that over the course of time, the child just is able to kind of flourish based on what they do well and less about what they don't do well. Okay, that gets kind of overshadowed. And so, they might, so the kind of the classic story here perhaps is somebody who and this is just one of many, somebody who, let's say, goes into sales. They are friendly, they are outgoing, a little impulsive, but they kind of have a handle on it, and they can sell you the Brooklyn Bridge, and they do fine in life. They're wonderful, and we can argue at Starbucks tonight about do they have a disorder. That's again philosophical argument. The last third are kids who have all those significant difficulties. Okay, these are kids who just have more difficulties of legal, medical, work-related, education-related, relationship-related, spouses, and so that's kind of what it looks like. Now, so let's get into treatment. When you talk about treatment, and this, remember I said that you're going to use, there'll be some things that are germane to kind of any treatment, not just treatment of ADHD, not just treatment of something in child psychiatry. This is it. So basically, everybody knows you weigh the risks and benefits, but let's complicate that a little bit. We're not just looking about the risks and benefits of medicine. We're looking at the risks and benefits of medicine versus the risks and benefits of other treatments that people might use, whether it be therapy or family therapy or academic interventions. Again, if you were only going to do one or the other, I mean, obviously you can do more than one, and you're always going to measure that against no treatment. Okay, no treatment. Remember my roommate, he who has a decision has a problem. So no treatment is a decision. It's a choice. It's a treatment choice. It's the choice not to do anything, and that can have consequences. So, and you have to be thinking about that, as a parent, about kind of what's the long-term outcome here if we don't treat, if we do nothing. Okay. Now, when you look at risks and benefits, let's look first, how do you measure benefits? Well, benefit is a word that we will all define differently, and there are many different types of benefits, and we will value them differently. So that everybody in this room probably values saving a life. And so, if that's the benefit, then we will probably, let's just keep it simple, we will probably, if there's, your relative is sick and you're going to use a medicine and it's got a lot of side effects, but we're going to save the person's life. Well, we're going to put a lot of weight on saving their life. Ending a tantrum. Well, what's a tantrum? I've got some parents who want the tantrum ended. Why? Because if they don't end the tantrum, the house is going to explode. The roof is going to come off the house. I've had parents who, it starts affecting marriages. Marriages split up over tantrums. I mean, there are tantrums with a capital T. Then there are tantrums with a small t that we've all probably done when we were children. The value, how do you value that? If your child doesn't have friends, well, making a friend, how much do you value that? The point in getting into college, like the truth is that, around here, and I'm putting myself in this, I'm not pointing any fingers, except, at myself. Getting into college is of great value. It's not true every place. So people are going to value things differently, much less which college. That becomes a whole other discussion, and I think we're back to Starbucks for that one. So there are lots of different goals, and we will value them differently. Now, how do you know, in measuring benefits, how do you know if a particular treatment is going to help you attain that goal? What doctors use are controlled studies. I mean, very simply, let's say you have 200 children with ADHD. They all fit criteria for ADHD. You put 100 over here, you put 100 over here. You give Ritalin to this 100, and the kids don't know that they're taking Ritalin, and the doctor doesn't know that there's Ritalin in the pill. And this 100 get fake pills, placebo. And then you do it for 6 weeks, and what's the results? I mean, that's it in a nutshell. That's what doctors like to use. That's kind of the gold standard for, is there benefit? Yes, 90% of these children had decreased ADHD symptoms, and 30% of these children had decreased ADHD symptoms. You bring in your fancy statistician, boom, 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 and they say, yes, that is statistically significant difference. Ritalin works. By the way, just a parenthetical comment. If I use brand names, it's only because I think you'll know them, although these days, as we'll talk about in a few minutes, you know the generic names too. That's another slide. But we decide that medicine works. That's the kind of gold standard for doctors. What do people, all of us, what do we use? We don't think in terms of double-blind, placebo-controlled studies in our lives. We think about vignettes, stories that we hear. My neighbor said that her son did great on Ritalin, but when he took Vyvanse, he lost weight. Okay, so I want this. And that's really the way that, it's the anecdotal information that that our brain is basically wired to use, that kind of anecdotal information, and that's what we all do. So I'm not finding fault, but it's worth thinking about, because I always tell people to just because our brain is wired for anecdotal information doesn't mean that you have to give it that much weight. You really want more scientific information if it's available. It's not always available. Okay, so actually Shakespeare used to bore me to death, but with a couple of Ritalin, I can see the underlying psychosexual conflict and in all its lyric and socio-political significance. So he is telling us that this stuff really does work. Okay, so that's another measure of benefit. How do we measure risk? That could be its own, We can do a whole lecture just on measuring risk of different treatments. However, all I want you to remember is this, okay? LIV. LIV is what keeps me awake at night, as you can see. What is LIV? Lethal, irreversible, very painful. Those three side effects, if I'm going to use a medicine with LIV side effects, it's not that I don't use the medicine, but I think about it and I think about it again. And I sit down with the parents and I say, look, here's the risks. Let's discuss it. Is it worth it? Is the potential benefit worth those risks? And sometimes the answer is yes. Now, again, it's a risk of lethal. I'm not talking about, no risk is 100%. If a medicine is 100% chance that you're going to die from taking the medicine, I'm not using it. Okay, that sounds like a ridiculous statement, but let's just set the boundaries here. So, but if there's a risk of lethal, irreversible, very painful, then you think about it and think about it again. If it's not LIV, honestly, I don't think about it much. So when you come to me and say, I don't want to put my child on methylphenidate, Ritalin, because I heard that it decreases appetite. And yes, Ritalin commonly decreases appetite, but it's not LIV. If you call me in 2 days and say, he hasn't had lunch for 2 days, I'll say, okay, let's try to figure it out. He's got to eat. We got to make sure he's getting enough calories. But it's not a reason to necessarily stop the medicine. Or if you say, look, I can't deal with a child who doesn't have lunch, I'd say, okay, let's stop the medicine. That's not a problem. Stop it. The next day, he's having lunch. It's not LIV. This is what keeps me awake at night. The other things, just kind of go with the flow. Again, that's easy for me to say, because you're the one on the front line. But basically, it's a simple way of looking at side effects. Okay. Now, so before we get into more details about treatment, I just want to leave you with this. Starbucks, you can sit by yourself in Starbucks and just think about this. So what is Obitrol? If you can name Obitrol, you get the book, even though you didn't know who Harvey was. So Obitrol was a medicine in the early 60s. It was used for, as you can see in the name, what do you think? Obesity, okay? It was an appetite suppressant. It was used in the 60s. It basically fell out of favor. I think that whole use of medicine fell out of favor. And then by the 90s, the company who owned Obitrol got sold. The new company found Obitrol in its, the box that it bought, and it decided to rename it. What is its new name? Raise your hand. Nope. Ta-da! There you go. Yes, so Obitrol became Adderall. So why am I telling you this story? Well, because when Adderall became Adderall in the 90s, appetite suppression was a side effect. In 1962, or whatever, it was a benefit to this medicine. 30 years later, the benefit became a side effect. It depends on what you value. And so it's just worth thinking about that. I find that kind of an interesting topic. Risks and benefits are fluid based on how you evaluate them. Okay, so let's talk about the treatment of ADHD. Medicine is the mainstay, and I'm going to talk more about that in just a couple of minutes. But just before we jump into medicine, let's just mention some of the other points here. So then there's behavior therapy. Behavior therapy is not a great treatment of ADHD, but, and I'll show you a study that kind of looked at that. If you have a child, I mean, behavior therapy to me is just like common sense. In other words, if you have a child who is impulsive and hyperactive and inattentive, and you can manage that at all by some kind of behavior modification approach, then do it. If you can, you don't have to cure it, but if you're doing anything good, then do it. It's got minimal side effects. It's just basically time and effort. And particularly with the kids with ODD, that becomes very important. In part because of the next part, the parenting part. So again, parenting did not cause ADHD. Excuse me, and parenting is not going to cure ADHD. But certain things that parents do, certain behaviors, certain ways of communication that parents use can really exacerbate things. And so, the kind of ongoing criticism, if you think about the number of times you have an interaction with your child, and from the time that they're, let's say, 12 months old, we won't do the numbers, but if you do the numbers, you're in the millions in no time. I mean, you're constantly interacting, and every interaction is different. But if you have like a lot of criticism, like you build up some pretty big numbers very quickly, and that gets somewhat ingrained in a child's psyche. It's generally not a help. Is there a child who says, you know what, I'm motivated. I'm gonna, it's kind of, I don't know if you remember the song. I don't know if this is directly relevant, but it just occurs to me. Johnny Cash's song, Boy Named Sue. Basically his father names him Sue because he knows that his life is going to be, because his father knows that he's a kind of a jerk and he's not going to be around to help his son grow up. So he names him Sue so that he has to be tough. And in the end, the Sue grows up and he's in a bar fight, and it turns out it's his father, who he's fighting, and the father kind of tells him the story. Anyway, you can listen to it, Johnny Cash, Boy Named Sue. But the reason I'm saying this, you can take the attitude that criticism kind of makes you stronger, and I guess to some extent, if it's done in a particular way, it does, but it can also do lots of damage. And kids with ADHD, for as often as they are impulsive, which is continuously, they hear it a lot. Not really great for the psyche over the long run. Other things like diet and like a lot of those things that people use, if one uses it and anecdotally it is helpful, go for it. However, if you look at the research, it's really not basically supported by research. So that's that. Now, social skills groups. I don't know that there's any great research that social skills group really work to teach social skills. However, forgive me if I wax nostalgic again, but if you remember, anybody remember Andy's Gang? You know Andy's Gang? Anyway, Andy's Gang was a TV show back a long time ago, and Andy Devine sang in the beginning, I've got a gang, you've got a gang, everybody's got to have a gang, and that was kind of the theme song, and it has stuck with me since I'm a little kid, that line, everybody's got to have a gang. Now, that's not entirely true, but it's true enough. And if a social skills group takes kids with ADHD and gives them a gang, it's like people who are their gang, that they like a lunch bunch or whatever, that's great. Like you might not be teaching social skills, but I still think it's a great treatment. Okay. School treatment. Again, we could do I'm not qualified, but you could take a whole course in this. Suffice it to say, there are a couple of just key points I would make. One is that it's important for teachers to understand ADHD. These days, more are understanding ADHD. Some are not. Some are still kind of, I feel like I'm looking at the paparazzi like this must be a very interesting slide because everybody's taking a picture of it. So, so teachers, there are still some teachers who are thinking in old terms. He should be able to do this. He's in 7th grade. Well, if I have a cast on my, I should be able to run a mile in, let's say, 7 minutes, but I have a cast on my leg and I can't. So having reasonable expectations and understanding what ADHD is very important from the teacher's point of view. If I had a choice, if I was king, I would make all the teachers of all my ADHD kids into kind of something like Jim Carrey. Like I would make them like interesting and like you just can't keep your eyes off them. But that's not the world, and I understand that. Then there are the behavioral treatments of ADHD, and this goes both for school and for home. So again, this is a whole topic, but just reducing it to a couple of key points. You want to keep an ongoing communication between you and the teacher so that those star charts are kind of getting back, going back and forth. You want to keep with the child a short feedback loop. What that means is that if you tell your child with ADHD, whether it's school or home, but I'll use a home example. If you say, it's 8 o'clock, go upstairs and put your pajamas on. And a half hour later, you check in. That's, I'll bet the ranch those pajamas are not on, okay? And then you're going to explode. Okay, that's your fault. Why? Because you didn't use a short feedback loop. How short a feedback loop do you need? I don't know. You have to kind of experiment. But if, there are children who you say, okay, it's time to get your pajamas on. It's 8 o'clock, go get your pajamas on. And then 2 minutes later, you call up. Joey, did you find your pajamas? I'm not here in the sink. I'm not, okay, that's a 2-minute feedback loop. Great. The ultimate is, come on, Johnny, let's go upstairs and get your pajamas on. And again, it depends on who the child is. And so there's no firm number, but remember a short feedback loop. And last, the use of rewards. Kids with ADHD are stimulus seekers. They love those rewards. And so, again, you have to think this out, but kind of use them, don't overuse them, but they can easily be probably a part of some part of your relationship with your child or the teacher's relationship with your child. And then last about this, homework. I have a friend who wrote a book, and in the book he said, if you want to put me out of business, lose the homework. And he's a child psychologist. And I had been saying that for years. And I called him and I said, I've been saying the same thing. I mean, basically, homework, this is a little bit of an overstatement, but homework kind of keeps me in business. It's just, the fights have been immense. So again, long topic, but finding a reasonable place for homework or a reasonable amount of homework for your particular child is useful. And that's kind of what 504s are for, actually. It can be. Although you don't need a 504 for that, you can just arrange it with the teacher that he does or she does certain problems and not all problems. Okay, now let's talk about medicine. So there are basically 3 different types of medicine that are used for ADHD. One, the stimulants, and you'll see there are 2 stimulants. That's all. There are lots of names, but it boils down to essentially 2 stimulants. Those are them. Then there are the selective norepinephrine reuptake inhibitors, which are used less. So Qelbree, which just came out relatively recently, and Strattera, which has been out probably 20 years now. And we'll talk a little bit about them. And then the alpha agonists, Intoneve and Capve, which we'll talk about also. What's important to know about medicine is, as I said before, about, like not all, even if a medicine is lethal, it's not lethal in everybody. It's a certain percentage, and the same with benefit. No medicine benefits everybody. There's always going to be a percentage, and it's, that's what we have to kind of base our decision making on. So, okay, so before we go ahead with the stimulants, just let's get this out of the way. Generics, because generics have pretty much taken over my life. I was going to say I hardly write prescriptions anymore for brand name medicines, except over the past 15 months with the stimulants, I write whatever I can get my hands on. Whatever my patient can get at the pharmacy, that's what I'll write. If they have, generic in stock, great, we'll go with generic. But I mean, you guys are probably aware, getting medicine since last fall, basically, has been murderous. And enough about that. I'll start crying if I continue that discussion much longer. But what about generics? So when a company comes up with a medicine, okay, they put in years of research looking at a whole bunch of molecules, and one molecule comes to, they say, you know what, we think this is a useful medicine. They test it, and eventually they go to the FDA and they say, we have medicine number 342 here, and we think that it works, let's just say for ADHD. You know what, let me change that. Let's just say for depression, just for a second. We think it works for depression. We'd like to market it and sell it. The FDA looks at the data. The FDA wants to see at least 2 studies, controlled studies of a certain size and statistical power, to show that the medicine works. And they want to see a list of side effects with what percent get whatever. And so the FDA says, okay, based on the data, you can market this medicine for depression in adults, because you didn't show us any research for people under 18. So you can market it for depression in adults. Now, and that stays under patent for a certain number of years. Then the patent expires, and then the other companies, the generic companies, say, okay, we're going to now produce and sell this medicine. They can't use the name of the medicine that the original company used. That's proprietary. But they can go to the FDA and say, look, we make the same medicine. Can we sell it? The FDA does not ask them to prove that the medicine works. Those 2 studies of significant power, statistical power. The FDA just assumes from the original research that since it's the same molecule, it's going to work. The generic company does not have to show side effects. It's simply, the FDA says, we assume the same side effects are from that the brand name medicine has. What they have to show is, I think it's called bioavailability, which basically means that the generic company has to show that their medicine gets into the body at about the same rate as the brand medicine. What does that mean, about the same rate? I forget exactly, but it's something like 75, I think, to 120%. In other words, it can get in a little slower or a little less. It can get in a little more, but it can't get in much slower or much more. It's got to be in that window. And that's kind of what they have to show. Okay. So, and then they can go and sell the medicine. So you now are using the brand name, and then CVS says, we can't get the brand name. We can get the generic. And you call me and say, is it the same? Well, yes and no. Is it the same molecule of medicine? Absolutely. Is all the rest of the stuff in the pill the same? Not necessarily, okay? Because the generic company, and I'm making this up because this is not my area of expertise, they use preservative number 6, whereas the brand company uses preservative number 7. One company uses color number blue, blue color. One color uses red color, and all the other things that go into packing a pill besides the molecules of medicine. Do those affect the use of the medicine, the effect of the medicine? Well, according to the FDA, it might affect within that window, but it's within the window. But people react differently. And so, is the medicine the same? Yes, and for all intents and purposes, it's the same. It should work. But is it really the same? No, it's not really the same. And some people are going to get a rash and somebody else is not. Or somebody's going to need a change of dose to get more in or less in. So again, slightly complicated answer, but that's kind of the issue with generics. So yes, you can use generics, but it may take some modifying of how you use it. And if somebody, gets a very bad reaction to the generic, then obviously they shouldn't use it. But I would say the same about the brand. Like sometimes you give a brand medicine to somebody and they break out in a rash and, they're allergic to, dye number 6 or whatever it is. Okay, now back to our stimulants. So stimulants come in immediate release forms. That means that it's usually a tablet, and the tablet has one dose of medicine in it, and it's released, and it goes in and it's absorbed by your body, and your body uses the medicine. Sometimes they come in capsules. These are sometimes tablets these days with generics, but think of them as more often capsules. And if you look in the capsule, you'll see different little beads. And the beads release the medicine at different times. So some of the beads release the medicine immediately when you swallow the capsule. And then some of the beads release more medicine, let's say 3 hours later. And therefore, the medicine that the immediate release form lasts 3 hours, with the capsule form lasts 6 hours. And then the pharmaceutical houses have gotten fancier. And so then you have something, let's say like Concerta, that's kind of built to release some now, some later, some later. So now it's, instead of X, it's 3X in duration. And then they make patches that last, and different liquids, and all sorts of fancy things that they're doing. And some of them are pretty interesting, actually. But that's an idea. So it's all the same medicine, but the delivery system is different, and it matters. Okay, what are the advantages of the long-acting medicines? Well, obviously, they last a long time. That's an advantage. They're difficult for my college kids. I mean, not all my college kids, but if you have somebody who you're worried might crush and snort on Saturday night a little tablet, then you give them a capsule, because it's hard to crush and snort a capsule. So when you have a long-acting pill, it improves compliance. You don't have to, back in the day, kids were going to the school nurse at noon to get medicine. Now, you take the medicine in the morning at home, and it lasts through the school day. So it kind of improves compliance. And some of the capsules can be opened and sprinkled onto like a spoonful of applesauce or yogurt for little kids. So that can be an advantage. On the other hand, the long-acting pills, because the drug company says it lasts 9 hours, don't believe it. I mean, they're not lying. I'm not accusing anybody of lying. I'm simply saying that people are different. And sometimes it lasts 6 hours, and sometimes it'll last 11 hours. And sometimes, they might say it lasts 9 hours because based on their testing, it does. But their testing might be very different than how your 15-year-old feels the medicine. She says, it only lasts 4 hours. Well, she feels it for 4 hours. Technically, it's lasting at 5 hours, but she just doesn't know it. I mean, it's a little, those numbers are a little fuzzy. Little kids, I find, tend to get, little kids meaning, let's say, kindergarten, first grade. If you want to add second grade, sure, but that kind of age and younger. So let's just say 6 and younger. I find are a lot more liable to get irritable on the long-acting medicines. Okay. I'm going to pick up the speed here just a little bit because I want to leave time for questions. How do the stimulants work? So if you remember, there's a neuron, and then there's a little space, the synapse, and then there's another neuron. So how does the electrical stimulation in this neuron connect with this one? Well, what it does, this one releases chemicals like norepinephrine and dopamine and others, serotonin, and they cross that little gap, that little synapse, and plug into this neuron, and then the electricity keeps going. What methylphenidate and amphetamine do is basically increase the amount of norepinephrine and dopamine in the synapse. That's kind of how it works. If you give either medicine, either methylphenidate, or which is like Ritalin, Concerta, kind of Focalin, or if you give them amphetamine, which is like Adderall, Vyvanse, some of the others, you have about a 70% chance of it working, which is pretty good. If you have somebody who does not respond, so the 30%, and you give them the other medicine, you get another 70% of them. So it kind of goes up. If you use if somebody doesn't respond and you end up using both medicines, you'll have about a 90% yield, which is really effective. Remember that number, 90%, because it's going to come up again for a comparison. What do the stimulants do? I mean, basically, their most powerful effect is decreasing impulsivity and hyperactivity. They also improve focus. And then there's like all the other things that if you look at research on people who take medicine, like what happens, well, they get more thumbs up from their peers. They get yelled at less by their parents. They have fewer traffic accidents. There's one study from, I think, Sweden that showed that when people were taking their medicine, they had, I think it was fewer arrests or less jail time or something like that. But that's kind of like the icing on the cake, the consequences of the good consequences. So yes, they work. Now, but interestingly, and this is kind of where that problem with the spectrum comes in, is that the stimulants improve the focus, okay, not necessarily hyperactivity because the person's not hyperactive, but the focus of people who don't have ADHD. So now, remember our spectrum, let's say you're in the middle of the spectrum, like you've got some symptoms of ADHD and the doctor gives you a stimulant, you're going to focus better. Does that mean you have ADHD? No, it just means that you're focusing better. People with ADHD have a greater improvement in focus, okay? But everybody, pretty much, is going to focus better on stimulants. That's why it's one of the reasons why I think the Navy was using them for like jet fighters, who've got to stay, pinpoint focused. Athletes sometimes. Okay. In terms of, if we go back to double-blind placebo-controlled studies, are there studies showing that the medicine works? Absolutely. We're not going to even go over it. There are like dozens and dozens and dozens of studies. Anybody who says the medicine doesn't do that, doesn't decrease hyperactivity and impulsivity and improve focus, just doesn't know, has never seen this. It's just, it works. Now, having comorbid problems, diagnoses, complicates things. And that's just, that's kind of the way it is. So I want to talk for a minute about the MTA study. This is not a study that shows that medicine works, though. I want to show it to you for another reason. So this is kind of a granddaddy study. It was done started in the late 90s, and I think they're still following. There's still research 25 years later coming out from this group. They took a whole bunch of ADHD kids, 600, I think, or something, 579, and they broke them into 4 groups. One group, group number 2, got medicine only by the research team. Group number 3 got behavioral treatment by the research team. And that behavioral treatment was intense. It was more intense than anything people in real life do. It was your government dollars, your tax dollars hard at work, because this is government-sponsored study. Group number 1 had both. So you have both. You have medicine alone, behavior therapy alone. And then the last group was community care. And that group was basically children who were just treated by their local docs, whether it be, I think, mostly pediatricians, maybe there were child psychiatrists in there, I'm not sure. But they were treated, if I remember, about 60% of those kids were on medicine. So they're not unmedicated. The majority were actually on medicine. After 14 months, they looked at the 4 groups, and what they found was that, and again, I don't want to get too much into the details of this because we'll go very far afield. But what they found was that, yes, combination therapy works better than everything. Medicine worked clearly better than behavior therapy. No question about that. What's interesting is medicine by the research team clearly worked better than behavioral therapy. But if you remember, in that last group, about 60% of them were on medicine. They didn't do so well. How come? And so here's the point at the bottom, the bottom half here, is that what the research team was doing was using higher doses and giving it more frequently. Now, when I say more frequently, this was before long-acting medicine. So, that becomes an issue, but in terms of dose, it's not an issue. They were using, the research team doctors were using a higher dose than the local doctors. And that made a difference. The point about this, and what I try to point out to my patients often, sometimes you start a medicine and you say, you know what, I think he's doing a little better. This is great. Thank you very much. That's the end of it. And then I get a call 2 months later. I don't know. I'm not sure it's working so well. And when you look carefully, you realize it probably was never really working, or maybe it was working a little bit. I say, look, let's go up on the dose. So we go up on the dose. Nothing. Go up again. We go up again. Wow. I didn't know that this is what I was looking for. If you look at the dose response curve of the stimulants, it looks like this. In other words, as you increase the dose, the effect gets more. It's pretty simple. And so what some people will do, it's not my style, but I appreciate the thinking behind it. I heard somebody lecture once. He said that he gives his patients Concerta, the smallest was 18 milligrams. He gives them 18s. He said, for the first week, use 18 milligrams. For the second week, use 36 milligrams, 2 18s. For the third week, use 3 18s, 54 milligrams, and then call me and tell me what you found. Okay, he's kind of pushing them to go up. And some people resist, but it's not wise to resist. I mean, basically what this slide says is simply, in the follow-up, the 8-year follow-up of the MTA, they basically found that the kids, at some point, they added another group to serve as a control. And basically what this says is that more important than kind of how the child, whether or not they took medicine for 14 months, that it was really more these other factors, the severity of the symptoms and, the intellect and conduct problems that had the greater impact 8 years later. Okay, side effects of the stimulants. The most common side effect, decreased appetite. Now and then you get somebody who's got a headache or a bellyache, not LIV. If it's very painful, let's stop the medicine. I mean, I don't want to do that to anybody. Slight increases in pulse and blood pressure, generally not an issue. The decreased appetite, it's an issue that needs to be monitored. It's not necessarily a reason not to use the medicine, but you do have to kind of follow it. Insomnia, if you take the stimulants at 9 o'clock at night, you're not going to sleep at 10 o'clock at night. Okay, that's why truck drivers use them to drive to Detroit. So don't use them at 9 o'clock at night. Use them earlier in the day. The longer acting stimulants can have more of an effect kind of later. Mood changes. This is a messy topic. Like when people say my child became depressed, well, before we say that, let me start the other way. As I said, younger kids and actually kids on the autism spectrum, they're more likely to get irritable, when they take the medicine. Now and then you have a child who gets kind of more anxious on the medicine, but that's not frequent at all. But sometimes parents will come in and say, that my child became depressed on the medicine. That is generally not accurate. And once we talk about it, the parents agree that it's not accurate. What they mean, when they're using the word, when I say the word depressed as a psychiatrist, I'm talking about extremely sad most of the day, hopeless, not able to enjoy themselves, maybe reclusive, in their room, not socializing, maybe suicidal. I mean, all of those things. That's not what they're talking about when they say depressed. When they say depressed, they're saying he looks flat, kind of affectively constricted. So the way I picture it, and we'll see if you get the analogy, but if you take Jim Carrey and you give Jim Carrey medicine, and a half hour later, you have Bob Newhart. Now, I don't know if anybody who's too young for Bob Newhart, he was one of my favorite comedians, but he had kind of a very kind of flat, constricted affect. You never saw him get really excited. That's what's happening when they take the stimulant, and they don't like it. And I understand that. And college kids will oftentimes kind of vote with their feet and say, I'm not taking this medicine. Like I don't, or they'll say, I'm going to use the medicine only when I need it, when I really need it, because I don't like the way I feel and I'm not as much fun, with my friends. Okay. Now, Just quickly, some controversial topics. This sudden cardiac death that came up, I don't know, 20 years ago, and in short, there's not a whole lot to say here, except that if a child has a congenital heart defect, or an arrhythmia, or there's a strong family history of arrhythmias, some kind of electrical conduction defect in the heart, then I have the pediatric cardiologist okay things before we go forward. I mean, rarely is it an issue, though. Height and weight concerns. There's, if you take a reasonable dose of medicine over the course of 2 or 3 years, what you will see on average, not all kids, but it's on average, is if this is, let's say, height, you'll see this. I don't know if you could see that. Like in other words, I'm going to exaggerate it like that. Well, let me exaggerate it and go like that, okay? You don't see that, like the child stops growing. That's not what we're talking about. We're seeing a less of a growth rate after 2 or 3 years on average. Again, not a big deal. What you do functionally there is you every 3 months or so, I weigh and measure kids, put them on the graph, and we plot their growth and make sure that they're staying on their curve. And most of them are not, it's not an issue at all. Occasionally it goes like this, and then it's never clear, and sometimes you have to get the endocrinologist involved. It's not clear, is it the medicine, or is that child just a slow, like they're a late bloomer, somebody who's going to hit their growth spurt later than their friends. And so that becomes kind of an issue. When you stop the medicine, though, early, the kids catch up. If you stop the medicine at age 18, they're not catching up. I mean, so this is an issue that occasionally needs to be followed, but it's not a big issue. Okay, great. Okay, excellent. So quick question, quick answer, and we'll move on. So med holidays. Originally, the research, or years ago, the research said that medicine holidays didn't really help this. But the more recent research, I think, is looking like maybe it does. And so if I have a child who's in that position and we can stop the medicine on weekends, absolutely. If we can stop it over the summer and holidays, sure, absolutely. Now, so let's just distinguish height and weight. Okay, because weight you can actually lose. You can kind of go up and then lose weight. Again, I don't find that to be a big issue, but it does merit following. That's kind of the bottom line. The tic issue, so tics meaning there's kind of motor tics. Years ago, this was a debate about do the stimulants cause tics. The research, and there's a lot of it over the past 30 years, says that medicine neither causes nor exacerbates tics. Now, that's what the research shows. Everybody has a case where they'd swear, you know what, I'm telling you, for this kid, and sometimes that happens, and it's hard to know exactly what to do with that. I mean, you can treat it, and there's ways of kind of treating both. When you have tics comorbid with ADHD, as you'll see, sometimes you use a stimulant or the next one of the other medicines from the other groups, which we'll talk about in just a couple of minutes. Okay, addiction and misuse. So 2 simple sentences. No, children do not become addicted to their medicine, period, end of discussion. However, are the medicines misused by some older kids, high school, college age kids? Absolutely. Again, Starbucks conversation. You know what? if it's okay with you, well, I'll do this kind of quickly because I kind of alluded to it before. Basically, you pick a meta-stimulant. How do you do this? You start at a low dose and you build up every few days, or let's say once a week. There's nothing magical about once a week. The reason I say to give it for a few days is because one swallow does not a summer make. So if I give your child medicine and you call me on Monday and say, oh, Dr. Kalikow, you're a genius, he's doing great. Well, I don't know if he's from the medicine, or maybe they're talking about, the Transcontinental Railroad, and your son happens to be the world's expert on the Transcontinental Railroad. Who knows? But 3 days, now I'm beginning to believe it. And why a maximum? Why do I have like 5 or 7? Well, because what parents sometimes will do is they'll start the medicine and then they'll call me a month later, say, I need a new prescription. I say, well, what happened? I don't know, I think it's working. That's not good enough, okay? I want you to stop, like after a week, and say, okay, is this working? Is it wow? If not, do we go up the dose? Remember my colleague who, says first week 18, second week 36, third week 54, like push it up. Should the school staff be blind to the medicine status? It depends who I'm talking to, okay? If I'm talking to parents, then I'm saying yes. Well, I'm being sarcastic. Let me not be sarcastic. So I used to say, I like the idea of the teacher not knowing what's going on, and in other words, not knowing the child's medicine status, because teachers are human like all of us, and if they know the child's medicine status, then their bias is liable to affect what they see. And then I presented that to like the school psychologists and particularly the school nurses. They were less than happy with my way of doing things. And I think in fairness, they convinced me to change. So I think that it's useful for the teacher not to know. I think you can get around that sometimes with some kids by telling the teacher that, look, at some point we're considering medicine, but we're gonna keep you blind to what we're doing. And because Dr. Kalikow says that you'll be biased, and usually if you explain it nicely, the teachers say, yeah, I get it, and there's no disrespect intended. And telling like the school nurse that the child's starting a new medicine, sure, like I have no problem with that. Okay, okay, so that's the stimulants. Next, so the selective norepinephrine reuptake inhibitors, Strattera, which has been around for a long time, and Qelbree more recently. I'm just going to point out so these are very different medicines than the stimulants. They don't work the same way, and they're not taken the same way. These medicines are taken every day, whether you need it or not. The stimulants, you don't have to, you can stop for 3 days and then take them and they work again. That day. With these medicines, no, you have to take it every day. It builds up in your system, and then it doesn't begin to work for a few weeks. It's different than the stimulants that work in 30 minutes. And last, their response rate, remember I said, remember the number 90%? This is why. The response rate for these medicines is closer to 50%. Something in like plus or minus a little bit. That's a big difference. And it makes it a little bit less dramatic when it works. If you give somebody a medicine and 30 minutes later, this hyperactive child is now sitting, doing a dot to dot of the Brooklyn Bridge, like that's dramatic. You'll never forget it. But with the medicines that start to work after weeks, it's not so dramatic. And so it's a little bit, that's a difficulty. Side effects, the major side effect I find is tiredness with Strattera. Qelbree I just have not used, and it seems the report I read is that it's got fewer side effects are experienced. And then the last group are the alpha-2 agonists. These are medicines like, Intuniv being probably the most common. These are medicines that used to be high blood pressure medicines, and maybe still are, particularly catapress, I'm not sure. But they're also used catapress, clonidine, short-acting clonidine, is the most commonly prescribed medicine by pediatricians for insomnia. Okay, why? Because the side effect of clonidine is tiredness. And so if we go from side effect to benefit, when do you want tiredness? Well, 10 o'clock at night sounds like a good time for tiredness. And so that's used commonly. They're also used, it started with clonidine, for tic disorders. And so remember I was talking about comorbidity with tics. Sometimes what you'll do is have a child on a stimulant, and you think maybe maybe it's making the tics worse, even though it's quote unquote not supposed to, according to the data, but it does. Sometimes you'll add Intuniv, which might treat the tics. Okay. Next. These are also medicines that you have to take every day and that take weeks to work. So with these medicines, so if you take Intuniv, which is long-acting guanfacine, it comes in 1, 2, 3, and 4 milligrams. So it's basically 1 milligram for a week, no response, 2 milligrams. I'm sorry, for 2 weeks, 2 weeks. 1 milligram for 2 weeks, 2 milligrams for 2 weeks, 3, and so forth, until you find something that works, and the response rate, again, around 50%. So, and again, side effect with these, sedation with the clonidine, Intuniv, that seems to be a little bit less the case. And you have to keep an eye on blood pressure because they are old blood pressure medicines. Excuse me. Okay, so basically, to kind of pull this together, if you look at benefit and risk, high and low, you want to stay in that bright green zone, okay? High benefit and low risk. That's what everybody wants, of course. You can't always get that. Sometimes you have to go into one of the pale green parts, but you want to avoid the red. If somebody, sometimes I have in Your Child in the Balance, I think I have a story about a child who was really kind of out of control completely, and the doctor decided to use a medicine. And the child was out of control because their parents were having a very difficult time, but it was going on and on. They couldn't do anything, and so they used a medicine that was, the risk I think was greater than the benefit, and would not work. So you want to stay out of that red zone, basically. Okay, so now back to value. So this quick story. So I just made this up. This is a conglomerate of people. So 12-year-old Aloysius, and I picked Aloysius because I don't run into many Aloysiuses these days, and so I figured I wouldn't offend anybody. So 12-year-old Aloysius, very smart. He's chatty in class. Everybody likes him. He's easily distracted. He doesn't get his homework done. I did my homework, Mom. I did it on the bus. Yeah, okay. Very good at video games. And he's getting B's and occasionally C's, but smart enough to get A's. The parents are kind of pulling their hair out. Like, what are you going to do with it? What do you value here? And you have to kind of measure, well, what's the prognosis for Aloysius? And, when is he going to kind of click in? Is he going to be one of those kids who prunes, and by the time he's, let's say, 15, he's kind of pruned and he's ready for, sophomore year of high school and get his grades up so he can get into a reasonable competitive college, which he's capable of? or not? I don't know. You know, like these are all parts of the calculation. Then you can take Cornelius. Okay, Cornelius, he's rigid. Maybe he's got some ADHD symptoms. It's not clear. You know, he's exploding every week. Not every day, not multiple times a day, but every week. And, you know, he gets frustrated and parents are walking on eggshells. What are you going to do with that? You know, you have to weigh what you value and what the various parts of this that are affecting Cornelius and other people in the family. You know, weighing the risks and benefits and measuring. But I guess the reason I'm giving you these two stories is because they're different, and they each demonstrate the many things that you have to evaluate in deciding what's going on here and what you're going to do about it. I'm going to just skip this. Okay, so quickly, and so these are just my 10 commandments, and I'm just going to highlight a couple. So from the kid's point of view, a diagnosis is not an excuse. My ADHD caused me to push my sister down the steps. No. The ADHD might have made it more difficult for you to resist the impulse to push your sister down the steps, but you have to own it. And again, I'm not saying, you know, Donna, you know, like, I'm saying that done in a reasonable way, you want to get your child to kind of take responsibility for their, for their diagnosis, even if using medicine is sometimes a help to them. Monitoring medicine. And I know that this is kind of difficult these days because finding people to monitor your medicine with you is kind of impossible, but it should be monitored. And because what you don't want to do is have the medicine rut. That the reason I'm taking the medicine today is because I took it yesterday. Now, for today and yesterday, okay, but the reason I'm taking the medicine this year is because I took it last year. Well, with ADHD, some kids are going to outgrow it. And so you want to continue to consider whether or not, you know, you need to, to use the medicine. So we've gone from kind of, you know, values and evaluations to medicines. I thank you for your patience. And I will tell you that just so the commandments, you know, are in the, like they're in your Child in the Balance. Most of the information about the medicines are in, not the new medicines, but are in the other book, Kids on Meds. And that kind of tells you more about like how medicines work and what. It's more detailed. In any case, I've got 5 minutes for questions. Shoot. And then 1, 2.